Hello. Good afternoon. Over to you, Dr. Jayesh. We should start the session.
Good afternoon, everyone. I'm Dr. Jayesh. I'm a critical care specialist at Server Surgical Hospital. And today's topic is regarding the common procedure in the hospital. In day-to-day life, we everyday face like IV cannulation, simple techniques, RT, and police catheterization. We start our session with the first topic, that is intravenous cannulation. This is a very common topic, but today we focus on actually what exact technique we have to learn, and what the complications we face there, and how to prevent that complication. So we'll focus on that only today. So starting with the first, we know around 90-95% of the patients in the hospital receive any type of any intravenous therapies. So veins are unlikely, they are superficials, they are dark and red in color, they have no pulse. So our today's aim for the intravenous cannulation is it should be safe, it should be effective delivery without any discomfort or any tissue damage, and without any compromising to the venous access if you need for a longer time. So different types of intravenous cannulations we know, ranging from first peripheral cannulas are the most common ones. Every day we keep day-to-day life we keep the peripheral lines, and we can keep it for around 2 to 3 days maximum, maximum to 96 hours, 4 days. But after that we have to change it. Other type are the midline catheters. You can say midline catheter, commonly known as the midline catheters, commonly known as the PICC line. Usually this type of catheters are needed in the chemotherapy patients for a long term. We can keep this type of catheters for at least from more than 5 days to maximum 1 month. So those patients who need longer duration of therapy, we put a PICC line in that patients. They are peripherally inserted, but the catheter tip is in the central vein. So basally cephalic we cannulate there, and the tip of the catheter is in the internal jugular vein in the superior vena cava. And the next one is the non-tunnel central venous catheters, commonly known as the central lines. Day-to-day life in ICU, every day in the patients with critical patients, we need that port. The indications for that are we need longer period of catheter with multiple ports. So in central line we have 2 to 3 ports, and we cannulate from the internal jugular vein. We can cannulate in the femoral vein also. We can keep it around for 12 to 15 days. We can maximum 14 days we can keep maximum. And next is the tunnel central venous catheters. They are basically used for the hemodialysis catheters. We can POM cath. Your common name is POM cath. You have heard. That catheters are usually for the hemodialysis patients. We can keep it just for less than maximum to 1 month. We can keep it. Last is the implanted ports. Implanted ports are the commonly known as the chemo port. Those patients who are need chemotherapies. For chemotherapy, we can keep it for a longer time. For 2 to 3 months, we can keep easily these ports. It can be done. What are the indications for IV cannulas? We all know that for sampling the patient's fluids, for administration of fluids, medications, for chemotherapy agents, blood and blood products. Hemodynamic monitoring, yes, hemodynamic monitoring also we can do, but it can be done by the central venous catheters. From the peripheral catheter, we can't do that. CV monitoring we can do. And last one is the hemodialysis. Next advantages. Disadvantages are compared to the intramuscular and the subcutaneous route. We have immediate effect, control over the rate of administration. If you need slow, if you need fast, we can easily do. And the patient who are not tolerating drugs orally or drugs and fluids orally, we can do the intravenous. And some drugs which are not absorbed by oral route. For example, higher antibiotics like carbapenems and polymyxins, we need to have the only IV access to be needed. Last one is pain irritation is compared to intramuscular and subcu, it's very less compared to them. It's said that doing a procedure, everyone knows sometime. But when we have not to do, it's very important. To do, everyone knows when we need, but not to do is very important. So exactly what some contraindications are. Some close infection, we have to say at the site of the insertion, we need to check the infection is there or not. Veins of fractured limbs, whenever there is a fracture, avoid their limb. AV fistulas, very, very important. If patient is a CKD patient, they have AV fistulas in their hand. Usually it is in a non-dominant hand. Conscious patient will be there. They will tell you that I have a AV fistula. Please avoid cannulation here. But whenever the patient is comes in unresponsive state or any emergency, you don't know. Patient can't say you. So at that point of time, before inserting any cannulation, you need to see if the patient is having a AV fistula or not. You can easily find that in the mostly in the left hand non-dominant dead is there. You will check any swelling is little bit of swell is there and continuous pulsation is there for indication for it. Next is excessive edema. You can't insert in that. If you get the line also within 2-3 hours, once the fluid goes, it will get out from it. So avoid that. And those patients who have bleeding tendency, clotting factors or any operation on warfarin, be cautious in that patient. It's not exclusive contraindication, it's a relative contraindication. Be cautious in that. Everyone have taken in hand this cannula, but different parts are there. Starting from the first, the needle is there, the catheter, the injection port is there, then the flashback chamber is there, and there's a white cap for the plug lock. Sometimes junior doctors are trying to ask me, sir, which benzo we need in which patients. So it is very important to check exactly which we need. Usually, what do they do? Whatever small veins are there, they get larger gauze and put immediately 22 line in there. But patient need too much fluids, we can't put them that. I have a question for audience. If patient comes with a trauma patients, those who need too large fluids to be needed for that patient, is peripheral line is good or central line is good? Central line. Any other answer? Okay. Actually, the answer is peripheral line. Why? Because there is a Hagen-Poiseuille's law is there, which says that the rate of administration for a cylindrical tube is directly proportional to the length of the tube and inversely proportional to the rate of the tube. So, central line length is very large, peripheral line is short. The gauze is around, we can put up to 16, 14 also. In central line, the gauze is around 18 and 16. So whenever you need a larger fluid, need to administer a large amount of fluid at that point of time, try to get peripheral line with smaller gauze. Okay. So 14 and 16 line is very important when we need a large amount of fluid to be inserted. And usually in routine we put only 20 gauze. Okay. And we have a color code for that. Usually pink color is 20, green 18, and 16 is the grey one. Okay. These are the commonly used peripheral line. Next, equipments we needed. We all know this. I don't go in detail in, everyone knows this. Site of insertion. Where exactly we need to insert? Whenever a new patient comes, immediately a staff or a junior doctor, what do? They take a peripheral line in the cubital fossa. It's a wrong technique. Always, first try to get in the dorsal region, distal region to be done, and gradually go to the proximal region. Start with the dorsal venous cannula network and then goes to the arm and above the cubital fossa. Why? Because once you prick in the cubital fossa and if the line get out and then you need to take other line in the distal layer, it will leak from there. So it's very important, always take first from the dorsal layer, distal area to be done. Nowadays a vena detector also there, but very less right now because of the cost. It costs around 4 to 5 lakh rupees a single piece. So right now it's not very commonly used. Available actually. If you get this, you are lucky. Because always when you get this, you prick here, you easily get the vein. So try to get this position. Then which veins are good and which veins are not good. We avoid good signs of vein, like it should be bouncy, it should be soft, always above the previous side, whenever you are pricking above the previous side, and refill when depressed. Visible veins are good, larger lumen veins are good, well supported, straight. Previously I told you a straight line is there, so straight veins are very good, and easily palpable veins. They are the good veins. So always try to get this type of veins. And which one is you have to avoid this? So avoid ones, thrombus veins, like thin and fragile veins we don't need, site of infection, edema, and those we have already multiple pricks we have already done, so avoid that type of veins. Preparation, get the equipments, get the trolley, every procedure to be explained to the patient and get a verbal consent for that. Position of the patient is very important. Identify the non-dominant hand and distal hand. Remember, non-dominant hand and distal. Dorsal venous network should be started with the first. Support with the pillow or some other matter and check contraindications we already discussed. Always, a single most prevention for the infection is hand wash. Hand wash, hand wash, hand wash, always. Perform hand hygiene, get equipments. Non-sterile gloves are okay for here. And remove the cannula from the pack and get all the catheter parts are working or not. Loosen the cap of right. Common mistake. We take a cannula, immediately insert in the vein, and the back side of the white cap is there. It's very tight before. And whenever you need that cap, because you have to insert in the catheter, we can't open that. Then we need someone else to open that. So before inserting line, we have to loosen that cap. So these are small things, but it's very important that. Apply tourniquets around 7 to 10 centimeter above the sides of the insertion and identify the vein. Clean the site with vein with the alcohol wipe and let it dry. I have seen no one let it dry. So unless and until you won't dry it, the infection contamination again it will be there. So I request all keep it at least wait for 1 to 2 minutes. It will dry. Nowadays 30 seconds also we can easily can be dry. Remove the protective sleeves of the needle and taking care not to touch at that time. Hold the cannula in the non-dominant hand. This is a simple procedure technique. If you know the proper technique, you will easily cannulate a good vein. So we have to hold the cannula in the dominant hand, stretch the skin and vein to anchor the vein with a non-dominant hand. So we have to insert at the angle of 10 to 30 degree at the skin. Remember 10 to 30 degree, it depends on the vein depth, how deep is the vein. At that point of time, you will see. Once you insert the needle, you have to lower the cannula slightly, ensure that it enters the lumen and does not puncture external wall of the vessel. What happens if once we get the blood in the catheter, we are too much excited and we put inside fast. At that point of time, what happens? It insert again the posterior wall of the vein. So we have to prevent that. We have to advance the needle up till the flashback is there. What is flashback? You can see here. Once we insert the needle, we can get the flashback here. And at that point of time, what we have to do, once the flashback is seen in the chamber, progress the cannula further for 2 centimeter. Or it's 2 mm only 2 mm. Then we have to fix. Then we have to fix the needle and insert the cannula. Insert it first, you get the flashback, hold it, then fix the needle here and insert the cannula in, not whole cannula with the needle. Okay, very important that. And then release the tourniquet. Then again, one biggest mistake all are doing that. Once you get the cannula, you have to remove the needle. I have seen maximum pair shaft, blood is continuously coming. So what they do, common mistake, they press here, but we should do press beyond the catheter. They press on the catheter and the blood will come. So we have to press beyond the catheter. Then only we can prevent this. Okay? The small things, everyone knows it, but in practical life we don't use this. So it is that's why we are doing this. And at last we have to remove the white cap and attach to the catheter. Remove the needle and cannula and dispose into sharp container. Attach the white cap. Secure the cannula in appropriate dressing. Then we have to flush around 2 to 5 ml of normal saline or attach to the IV side. Okay. And for securing the cannula, we have to attach the transparent dressing. Everyone what a Dynaplast they are using or non-transparent, they are not good. Why? Because we don't know exactly there is an induration is there, any redness is there, any pus collection is there, or any leak is there. So always attach the transparent. Document what we have done, date, time, size, site, any problem encountered during the insertion. Review the date and cannula should be no longer for 72 to maximum 96 hours. But before that also, if any induration is there, any redness is there, you should remove it. take time to the patient and clean up the mesh. Potential complications. Remember potential complications, we always, I told you before only, what we are doing everything, we know everything, but whenever we have to stop any contraindication, at that point of time, because we have to prevent the complications. So at this point of time, we have to see the first most common complication is the IV site infection. First collection is there, inflammation around it. At that point of time, we have to remove the line as soon as possible. Hematoma. Common mistake done by all the staffs or junior doctors. They prick the needle, cannula, they get the blood in the cannula, and they pick the insert little bit of more and puncture the external wall. Then what they remove the cannula immediately, and they never ever they press there. They immediately take another one. But at that point of time, we have to at least press for 1 to 2 minutes to stop the bleeding, to clot that site. So it is very important. You have to clot that. Next is bruising is very common. Phlebitis. After you will see after in ICU, day to day every day I have seen the ICU. Within peripheral cannula for 2 to 3 days. After 2 days I have seen big phlebitis is there because of high concentration medicines. So that's why we prefer whenever every patient in the PGP, all the doctors tell us why you need central line because of this. High concentration medicines, NORAD, and we have to put that. At this point of time, we can't do with the normal peripheral line. We need central line for that. Extreme critical extravasation. Whenever the high concentration medicines like potassium or anything goes to the peripheral line and get extravasate, after 2 to 3 days they get a necrosis. So regarding my first talk regarding the IV cannulas, any questions we discuss at the last of the topic. Next topic is regarding the IV urinary catheterization. Male, female, little bit of anatomy is different, so little bit of we have different thing. Procedure, little bit of difference. I will let you know what is it. One by one we discuss everything. First is the indications. We have a diagnostic indication, therapeutic indication, surgical indications. Those patients who are need monitoring, urine output monitoring is there for the image purposing like X-ray KUB or X-ray any CT KUB. At that point of time we need a Foley catheter for the inserting the contrast. Therapeutic like acute urinary retention. Most common in the ICU, accurate measurement of the urine output in the critical ill patients. Each and every hour output is very important because of the AKI definition for 6 hours output. We need each and every hour output is there. Initiation of any continuous bladder irrigation, intermediate decompression of the bladder, prolonged immobilization. Stroke patients, those are on a bed ridden, we need then that patients. Neurogenic bladder dysfunction, in that patient also we need. And in surgical patients, all we need for a short period of time like urinary gynec and long-term fracture. Again here, very important, Foley catheter inserting is very easy, but when not to insert is very important. If patient is a pelvic fracture or patient is a urethral injuries and you insert a Foley there, you will come in a havoc situation. So we have to avoid it. The most common is the traumatic urethral injury, increase in the urethral stricture, resistance of the passage. So never ever force while putting an incision. High grading prostate or you see a blood at meters. You have to avoid that. Risk associated with the catheterization. Urethral injury is the most common when you are using the inappropriate size or inappropriate catheter or inappropriate with the force you are using. And next is the urinary tract infection when you are using a poor technique. Sterile technique to be done if you are not done. Bladder spasm or pain and Cole's passage. Different types of urinary catheters are there. Straight and intermediate catheters, commonly used, straight and intermediate procedures. Indwelling catheters, suprapelvic catheters are the indwelling catheter itself, but because of anatomical insertion site is different. Indwelling catheter we insert at the urethra, and for suprapelvic we insert from directly the bladder at the small incision taken to at the lower abdomen. And the next one are the external catheters like condom catheters. Here first we see the indwelling catheters. We have 2 types of catheters. The material is different, latex and silicone. Difference is there, latex catheter we can keep up to 15 days and silicone catheter a little bit of more, up to 1 month to 1.5 months we can keep it. You can see here this is the two-way, sorry, this is two-way Foleys and this is three-way Foleys. Normally we use two-way Foleys. Three-way Foleys is used whenever there is we need for the irrigation. Neurosurgery patients are there, one side is a continuous irrigation, at that point of time we need three. Another are the intermediate catheters like K90 commonly used when we need for a single time. We can't use for completely because there is a no balloon at the inflated balloon is not there. Third one is the external catheters. There is a condom catheter commonly used. Those patients who know there is no complication regarding the urinary tract, only the complication with patient is a bedridden or immobilized patient. In that type of a patient, we try to need for the condom catheter only. Parts, again, Foley's catheter is most commonly used. You can see that there is a bladder opening with a balloon with a filled with the water. Can you put air in this? Can you put air? Why? Why no? Yes, sir. No, but the one-way valve is there, so no need. See, whenever in bladder there is a water is there, and we have to attach at the neck of the bladder. If you put a air, already liquid is there, okay, it will float in there. It will float in the bladder, okay. So we need air to attach at the neck of the bladder, okay. So it's very important there. There is a drainage tube, there is a silicone latex material is there, and there is a size, different size again. This is from 6 to 26 size are there, and commonly used are the 14, 16 and 18. In female 14, 16 and male we have to insert the 16 or 18 we can easily do. Again preparation, everyone knows this all. We need sterile techniques. So there is a no greater satisfaction to a human than a pass a urine. So it is very urgent. So without any delay, we start the procedure. For the procedure, explain the procedure to the patient, get a consult, maintain the privacy and adequate lighting. Position is very important. For male, female, both are different positions. For male, supine position, and for female, it's a dorsal recombinant position. Means supine position with a knee flexed and should be apart from around 50 to 60 centimeters. First we see male catheterization and then female catheterization. Little bit of changes I will let you know. So perform hand hygiene, very very important. Putting a IV line, non-sterile technique doesn't matter, but for putting a urinary catheter, it's very very important to be sterile. You, your hand, your surrounding too. So it's very important for that because UTIs are very very common to be complicated for that. So proper position to be given. We have to paint with the povidone iodine, 10% weight by volume from. Always I've seen wherever they are doing procedures, they only put a betadine over the genital area. No, we have to put from lower abdomen to the thighs. Complete repair. Then with a non-dominant hand, we have to grasp the penis below that gland, just below the gland, and hold it upright. If the patient is uncircumcised, you have to retract the foreskin. Remember, whenever you retract the foreskin, after procedure you have to put it again, same thing. With the dominant hand, clean the penis with the povidone. Each and every time you use the new cotton balls. Don't use the same one. Then again change the gloves and drape from lower abdomen to the thighs, and place the fenestrated drape. That means normally use the wound towel. Then with a dominant hand, with a non-dominant we have to strengthen the penis and angle of 60 to 90. Small thing, but always try to get maximum angle so you can put directly to the inside the catheter. You have to hold with the non-dominant hand, insert the 2% of lignocaine jelly and hold the meatus. Again we have to wait for 2 to 3 minutes. Always what they do, we do inject the lignocaine jelly, immediately put the catheter. No, if the anesthetic effect is not there, you may patient have a pain, anxiety, and it may get trauma. Okay, so always wait for 3 to 5 minutes and then gently push the lubricated tip of the catheter into the urinary meatus. Then continue to advance the catheter completely till the bifurcation. Whenever you are doing the male catheterization, we have to insert till the bifurcation. Y mark is there wherever. And we have to see the urine flow. If urine flow is not there, you have to need something is wrong. It may be in false track also. Once you get this Y mark and you get the urinary catheter flow, immediately attach the syringe with the sterile water and inflate the balloon as per the manufacturer advice. Remember, usually it's from 10 ml to 30 ml, but different companies have different balloon size. So usually in 15-14 French it is 10 ml and 15-16 French is around 30 ml of sterile catheter to be inserted. So gently pull back the catheter until the balloon engage the bladder of the neck. I told you before, you have to engage at the neck because it will again, we have to prevent the leakage of that. Attach the drainage bag at the position below the bladder level. Whenever you are inserting the bag, you have to attach below the patient's level. Okay? Secure the catheter at the thigh and avoid the tension. You see there is no tension. Patient is moving a little bit off, so there is no tension at the catheter. Remove the drapes, cover the patient and encourage the drainage bag is attached at the bed frame. But I have seen many times that the bag is lifting at the floor. No, we have to hang it somewhere in the bag. Then remove the gloves and gowns and perform a hand action. For female, little bit of difference because of the anatomy. Again same, we have to supine position with knee flexed. With the thumb, we have to clean that area. With the middle and the index finger of a non-dominant hand, we have to clean the labia majora and labia minora. Pull slightly upwards. Locate the urinary meatus. Very, very important. I have seen with my eyes also. A junior doctor had inserted a catheter in vaginal orifice, and they told, sir, I can't get urine inside. So, as a male, naturally we are not doing female catheterization every day, but we have to know good anatomy, then only we can do this. So first find exact where is the urinary meatus for female and then try to insert. Okay. Then we have to, with the dominant hand, we have to clean the urinary meatus and using a iodine, betadine basically, clean the drainage vessel, change the gloves, and we have to open the sterile and put in the drape. Pick up the catheter with the dominant hand, insert the lubricated catheter into the urinary meatus. Here is the difference against the male. In the male, we have inserted the catheter till the bifurcation. But here, can anyone know what is the length of the urinary urethra in the male? Anyone? It's around 15 centimeters. In female, it's around 4 centimeters. So that's why in female we have to insert around 5 to 6 centimeter inside. At that point of time we get the urine and we have to advance 1 to 2 centimeter further. We don't need to further completely insert that. And then attach the syringe. You get the urine, attach the syringe and inflate the balloon and gently pull out the balloon till the neck of the bladder. Secure the catheter at the thigh, same. Complications. Urinary complications are very, very important. In ICU, I have seen urinary old age patients, more than 50% of patients have the urinary UTI. So we have to prevent this. First most common is the CORTI, it's a catheter associated urinary tract infections. How can we prevent this kind of infections? Consider alternate catheterization. Try to avoid Foley's catheterization. At that point of time we can use condom catheter if possible, or not to use catheter. Okay. Next, connect with the securement devices. I have seen many times we put a dynaplast or we put a little bit of micropore, patient try to move and it's lost. So you have to prevent adequate good amount of time because you have to prevent the traumatic event in the police. Third, we have to keep it clean, use proper sterile technique. Fourth, always keep it closed. Once you have inserted the catheter, you attach the tube, you have to keep it closed. Whenever you need the sample from a urine sample from the catheter, how will you get? Any answer? Whenever patient has a Foley's catheter in situ and you need urine collection, how will you get it for cultures? Anyone? Sorry? That's why I told you. Keep it close. Can't open that. Get a syringe, insert at the Y angle because the latex material one way valve is there. Get aspirate from there. Okay. Always keep it closed. Okay. Next is call for removal of when there is no longer needed. If Foleys are not needed, immediately remove. And when there is a signs of infection. Usually cultures, not to send cultures officially. Patient have a symptoms or patient is anything else. Hemodynamic unstable. At that point of time, only you send the blood urine cultures. Second is paraphimosis. In the beginning, we discussed that whenever you are retracting the foreskin, if you are not again replacing that with the same position, after 4 to 5 days, you get swelling around the veins. It's very worst. If very critical, then we need a small surgical procedure also. So always, if you are retracting the foreskin, place it back. Next is accidental removal. Very important. Day-to-day life, patient can get this. And if you are getting this type of patients, do not reinsert. Always not to insert again. If patient is passing urine, is okay. If not passing, consult to urosurgeon. Other complications are urethral injuries can occur because of patient goes to the false track can occur. It's urethral strictures maybe, and patient get a urethral rupture also, perforation. While inserting a catheter, you don't know exactly, you didn't get the urine in the backflow, and you inflate the balloon. It will get ruptured. So little bit of this complication can also be occur. Next is the catheter blockage can occur, so you have to avoid. Last one is the bladder dysfunction. So some post catheter cares are there, do's and don'ts are there. So always perform a hand hygiene, keep it clean. Always before and after perform hand hygiene. Very important to prevent any kind of infection. You have to keep clean gloves handling the catheter while drainage or handling the catheter. Always keep away the kinking and becoming obstructed, and keep the catheter always closed system. Don'ts are the we don't need catheters of urine collection at the routine basis. So don't change every 10 days or every 15 days. If patient has a symptom, that point of time you think that we need to change. No need for antimicrobial prophylaxis. I have seen many patients inside a Foley catheter they start the antibiotic. No, prophylaxis antibiotic for urinary catheters are not required. Don't use antiseptic while cleaning the catheter after the catheter is there. During procedure we have to do, but after the catheterization for regular cleaning, not to use the antiseptic. Don't routinely screen for antibacterial. If you see the pus collection in the catheter, but patient is hemodynamically stable, patient has no fever, not to worry. Don't send cultures. Wait for them. Okay, nothing will happen. And do not contaminate the catheter outlet while during the urine collection and bag empty. Some alert signs we get, like whenever patient is a accidental removal, be alert. Not to reinsert the catheter. If any bleeding or anything, contact urosurgeon. Fever, if patients are getting fever 103 or more than that, 101 more than that, we have to do that. At that point of time, we need to think about that. If no urine in the bag, patient previously was urine was there and urgently immediately urine is not there, we have to be alert. Foul smelling and any blood in the catheter, be alert. And in persistent suprapubic pain is there, at that point of time again we have to be alert at the point of time. So good tips for good catheterization are the always provide a proper privacy to the patient, watch the patient face during each step, communicate to the patient and explain what you are doing, and do not use excessive force ever. My last talk is on the nasogastric tube, very simple procedure. Again different sizes are there. It's a soft kink resistance PVC tubing is there. Can anyone tell me what is this green line suggest? Why this green line and there is a tip green here? So what is the use of that? X-ray. Okay, good. rightly said that first this here the green color is because of the color code. Different sizes are there, ranging from 6 to 20, and different sizes. Usually in adult we put from 14, 16 and 18 size. And you can see here there is a radio opaque line is there. For the X-ray we can easily see that. Some indications for feeding the patients when the oral intake is not inadequate or patient cannot take oral, for admission of medications, for emptying the stomach when we need to for example when we need the patient to intubate the patient, it can prevent the aspiration, and some to remove the GI bleed and clots. To decompress the stomach and to decompress the gastrointestinal tract for obstruction in the ileus patient. To remove the injected toxin, gastric lavage commonly used, and to aspirate the gastric content for the analysis. Again, contraindication is very important. Better than indications, we need to remember contraindications first. Contraindications, some are the absolute contraindications. First is severe maxillofacial trauma. Sometime in these patients we get a skull base fracture. My last slide I will show you a havoc situation, complication can occur with this situation. So always think, always you will get a proper history before inserting an RT. RT is a very common procedure, but sometimes it gets havoc situations. Nasopharyngeal and esophageal obstructions, esophageal abnormalities like patient having the ingestion of any corrosive agents. So we have to avoid that. Diverticalized strictures because of the high risk of esophageal rupture. Some related contraindications are patient has a coagulation abnormalities are there, or recent interventions like esophageal bending have done previously. Again, equipments, nothing too new in this, so we will skip this. Procedure. Explain the procedure to the patient. Position is very important. Foley's position is there. If comatose, semi-Foley's position. Basically, we have to put in the sitting position, and the knee flex around 0 to 45 degree at angle. And second, determine the length of the tube. For determining the length, estimation of the length of the tube from the tip of the nose to the ear lobe, and then the ZP sternum angle. So it's approximately around the length is around 40 to 50 centimeters in all, depending on the length of the height of the patient. So procedure, we will examine the nostril for any deformities or any obstruction to insert the best insertion. Perform the hand hygiene, clean gloves, lubricate the 2 to 3 inches with the lubricant, and gently insert the tube into the nostril at the back of the throat, the posterior nasopharyngeal area. Once it reaches there, we have to flex the head of the patient towards the chest, and ask the patient to have a sip of water. If patient is conscious, we can do this, but if patient is drowsy or unconscious and high risk of aspiration, at that point of time we won't do this. At that point of time, RT is not usually there. You have to rotate the RT little bit of time and then try to insert, but do not use force at that point of time. If any resistance, not to do that. Patient will once ask the patient to sip of water through a straw and advance the tube during the swallowing. Patient will swallow the tube, facilitating the passage into the esophagus. Continue advance the tube during the swallow and pretend depth before you had already marked the point. At that point of time you will see. Do not force tube. If resistance is there, if patient starts cough, choke or any cyanoticus, stop the procedure immediately and pull it back. Check the correct position. Can you tell me how to check the correct position? By stethoscope. Okay. Anyone else? Okay. Okay, one answer from sir is that we can take a glass of water and put the external port there for air bubbles, to check air bubbles. Okay, anyone else? Aspirate. Okay. Again, anyone else? Still, we didn't reach that the gold standard. What is the gold standard? Excellent. Very good. Okay. So only the last two answers were perfectly right. One was the X-ray, and the second was the aspirate. We discussed a little bit of that. You have to secure the line and location. So X-ray. X-ray is the gold standard. But nowadays what we are doing, we are inserting air with the syringe and check with the stethoscope. we can misguide from there. We exactly don't know exact. It's not confirmation test, so we have to avoid that. The gold standard answer is the always do a X-ray if your available is there. Okay. How we know that? You can see the radio opaque line is there, and it reaches the tip of the RT is in the gastric region. With this, we can confirm that the line is in the RT is in the exact position. The second one is we can aspirate a small amount of gastric juice from there, and we can keep it on the pH. There's a pH indicator strips are there available there. We have to check with that. The gastric content is always acidic, so the pH is around less than 5.5. So it's acidic material. So we can, these two methods are confirmation for that. So never, I suggest you not to use stethoscope and insert the air inside. You can see that if you are not getting exact amount of in the aspirate, if your pH is more than 5.5, this means RT is in the lungs. Second is RT, it doesn't reach the gastric content, it's at the esophagus only. And third one is that the RT reaches the catheter, again it recoiled back to the esophagus. So you have to take care of that. Sir, during procedure I already explained that. During the procedure, this patient getting coughing, but as an intensivist with the ICU, we don't exactly the patient is coughing continuously. It can be there. So for confirmation, X-ray is the best. Observe the patient determining the response to the procedure. Alert sign in conscious and in drowsy patient also. Whenever patient is a continuous gagging, you have to prolong intubation is stimulation of gag reflex. You have to be careful because there is a high chance of vomiting and aspiration. So immediately when you are inserting the RT, you confirm the RT, then aspirate adequate amount of fluid. Coughing indicates the presence of, as sir told, coughing is an indication for the RT in the airway. Complication. First is nasopharyngeal trauma with or without hemorrhage. When you are inserting RT, be careful, do not force it. Second, sinusitis, sore throat. If the RT keep it for a prolonged period, it can we get this complication. Pulmonary aspiration, sometimes it gets aspirated also. Traumatic esophageal or gastric hemorrhagic and perforation occurs. One most rarest complication, but if you get this complication, you fall in a havoc situation. My first contraindication was maxillofacial injuries, and it can have a skull-base fracture. One that I have seen in my life. What is this? RT in the brain. No one have think that it can this can also can happen. So be careful, avoid whenever you are doing any procedure. Contraindication is very important. First to listen them, then something. So this is RT in the brain. The tip of the RT is here. Definitely. That's why we are telling you. So my final talk is the success of any procedure with the increase with the good amount of proper equipments, proper technique, familiar with the anatomy, and last practice. Thank you. Any questions? Yeah. So now there is a new material, PVC soft materials are there. We can keep it for a long time also. Yeah. Right now it's PVC. Non-kinked, my first slide also there is only there. It's a non-kinked resistance. Yeah, non-kinked. We can do that, but nowadays already the materials are very thick. They have made the kink resistant material is there. So nowadays it's good. No issue, no need for that. Previously it was there, the sir told the rubber catheters were there. At that point of they keep the RT in the freezer for a few of time, then they try. So I think some of audience came late. My 3 topics were there. Normal peripheral lines, Foley's catheterization and RT. Any question related to this you can ask. Peripheral veins. Okay. In short I will repeat that. Okay. You need PPT also, or only I can repeat? Okay, I will say. Madam, 5 minutes. I will take more 5 minutes only.
Running little short of
Yeah, yeah, yeah. See, our IV line, our main aim is just to, it should be safe, it should be easily delivered without any discomfort and tissue damage and compromising any venous access. So this main thing, our aim is there. Different types of catheters are there: peripheral line catheter, tunnel catheter, midline catheter, non-tunnel catheters, that is CVC line. We only focus on the peripheral line today. We already discussed in detail. We all know indications, what are indications are there. Advantages over the intramuscular and the subcutaneous. Contraindications are very important. Never ever take a peripheral line at the site of infection if you find any infection. If you find any fractured limb, that avoid that. Avoid in the AV fistulas. Wherever patient having AV fistula, mostly in the left hand or in the non-dominant hand, we have to avoid that. Excessive edema, avoid that. And any bleeding tendency patient having, at that point of time we have to avoid, but it is a relative contraindication, not absolute contraindication. Different sizes are available ranging from 14 to 16. One question was there, at the time of the when we need to traumatic patient, we need to give large amount of fluids. At that point of time, peripheral line is good or central line is good. Okay, you know the concept that because of the size we have to go to the peripheral line. So put a smaller gauze, 14 and 16 gauze at the point of time, and give large amount of fluids. Because in peripheral central line, the gauze are around 16 and 18. Here we are putting at the 14 and 16, and with a smaller length, so fluid will go more faster. So at that point of time, commonly used are the 20 ones. 20 and 22 are 22 and 24 in the pediatric patients, but the 20 line, at least whenever you need to insert a peripheral line, put a 21 first. You all know the equipments what we need. Insertion, site of insertion is very important. Whenever a patient comes to you, immediately what we do, we put a peripheral line in the cubital fossa. Please avoid that. Start with the dorsal venous network, then go distally, then go proximally. So starting with the distal, then go to proximally. Venous detectors are there. If you are finding this type of veins, very good. You have to insert at the straight line. Some are the good veins, some are the bad veins. What are the good veins? Bouncy, soft. We always put prick at the above the previous site. Where the previous site is there, at that point of time we have to prick. Straight veins are good. Easily palpable veins are better. We have to avoid this type of veins like thrombus veins, thin, inflamed, and bony, veins near to the bony prominence. We have to avoid that and have undergo multiple previous punctures. We have to avoid that type of limb. Preparation, we all know. Procedure, I go to a small with the procedure. Hand wash is very important. Non-sterile gloves. We have to remove the cannula from the packing and check all the parts are operational or not. Apply the tourniquet around 7 to 10 centimeter from the incision site. Clean the site with the alcohol wipe and allow to dry. Please allow to dry at least for 30 seconds. Then remove the protective sleeves and hold the catheter in the dominant hand and stretch the vein and insert the catheter at the 10 to 30 degree of angle, depending on the length of the, depending on the depth of the vein. So always at the insert side will be at 10 to 30 degree. Once you insert the catheter, once you insert the vein, at that point of time, we have to little bit of lower the cannula slightly, and then do not puncture external wall. What we do, insert the once we get the blood, we immediately insert little bit of more. But what will happen? It will prick the external wall. So at that point of time, you have to hold the catheter immediately, slowly remove the needle, and then drag the cannula inside. Not to drag hold the vein. And finally, we have to release the tourniquet and apply the gentle pressure over the vein beyond the line, not at the catheter, and secure the line. Okay? Yeah. So it is a relative contraindication, peripheral line. There is no absolute contraindication. See, blood thinner, if usually peripheral lines are not to get too much blood, but we have to be careful in that. not to prick again and again. Try to prick in a single prick only. And at that point of time, you try to get at the vein flow at the cuboidal fossa also, if any emergencies are there.
We are going late.
At least we can more than 96 hours we can not more than that. Vein finders are very costly right now. It's a 4 to 5 lakhs rupees a device, so it's not easily available. Yeah, 4 lakhs at least.
So we shall bring an end to this
Thank you.
topic, and I
Thank you.
understand our faculty
Thank you,
will be
everyone.
more than
Dr.
happy to
Jayesh.
take up the questions in the common hall area. I thank the chairpersons and the faculty both for a nice session. So after bombarding our brains since morning 9 o'clock, let us now move over to the mind. The next topic session for today will be Heal Your Mind. And I would invite Dr. Digamba Naik sir from Goa, who is the author, a social activist, besides being a cardiometabolic physician. For the next talk, I would like to invite our two chairpersons, two senior physicians of Baroda, Dr. B.R. Shah sir and Dr. Prakash Shah sir, to please chair the session.
सर कौन सा चलाना